infected ear, and you'll see in a moment, this is the pre-procedure examination video. So just as we enter the ear canal there, you can see a huge swelling, so some edema, and it's very lateral, it's right near the ear canal entrance, and that could be one of a number of things. It could just be an ear polyp. It could also be a sign of malignant, or what we call necrotizing otitis externa, which is potentially life-threatening. It typically occurs in patients who are diabetic and have a weakened immune system, and the hallmarks are they experience excruciating pain at night, more so than the day, and with that does need urgent kind of treatment from an ENT specialist. Other hallmarks of necrotizing otitis externa, or another name given to it is malignant otitis externa, is that it occurs typically at the base, the floor of the ear canal, which you could say this is, but there's typically a lot of granulation tissue. So granulation tissue is a reddish connective tissue which occurs during the healing process on the surface of a wound. Can't really see that on this case. Another plausible alternative, it could be a furuncle or a boil, which is typically blood filled, and you can see all the blood vessels, but again, that's not very apparent here. So I would hedge my bets really that this is either an ear polyp or just some edema, some swelling, inflammation due to otitis externa, so that's an outer ear infection. The client is diabetic, but he didn't report any excruciating pain or any pain at all whatsoever actually at night. So you can see here that this swelling has literally occluded the majority of the ear canal, and I've got very little to work with at the roof of the ear canal, so the superior aspect. In fact, I know on camera it looks kind of still quite a large aperture, but in reality it's not. Remember, we're using an endoscope and there's high levels of magnification there. And I've had to actually use a fine end gauge. So a fine end gauge is a lot narrower and slimmer in diameter to the standard Zollner suction probe, which is a 2mm tip suction probe, and the standard Zollner suction probe, I was finding it very difficult to insert. Before I proceeded with the procedure, I just wanted to ensure that that swelling wasn't really uncomfortable, so I did make contact with it with the fine end. That wouldn't have been shown on the video, and despite that swelling, the client found it quite comfortable as I made contact, so that was reassuring. The client has had a remote consultation with his GP, who's prescribed some antibiotics, some ear spray, but with all that impacted wax and with that swelling as well, maybe they might benefit from some oral antibiotics possibly. He did see another audiologist who I don't blame, kind of referred the patient onto myself, that they weren't comfortable doing the procedure given the appearance of the ear, and I think that should be kind of commended really. Any specialist, if you're not comfortable doing a procedure, I don't think there's any embarrassment in that, and this particular audiologist actually has referred a couple of complex cases to me in the past as well, so I think that should be commended. I don't think that should be seen as a failure. I think everyone should know their limitations. For example, when I first started performing clinical ear care, I probably wouldn't have attempted this procedure, and I would have referred to my colleague Mr. Darish Rajali, who's an ENT surgeon, but you see, I've done many procedures now, and kind of I like to think I'm skilled enough and experienced enough to kind of undertake these complex procedures. So we just went in there with a standard Zollner suction probe, because I was finding it very difficult. You can see there's a lot of keratin at the top, a lot of dead skin, and it was quite fibrous, so it's very adhered to the canal, and that fine end really wasn't cutting the mustard. So I did temporarily go in with a standard Zollner suction probe, but because the whole ear canal, there's a lot of edema, swelling, what you tend to find with a 2mm standard Zollner suction probe is when you enter the ear that's already inflamed, the canal itself kind of collapses, and I'm assuming that fluid within these cells, they get attracted by the vacuuming, so the ear canal actually seizes and closes, so I find it a bit tricky. You can see there I've kind of got wriggling out a piece of wax, so there's two challenges here. First of all, three. First of all, is getting access to the wax and even seeing the wax. So I would say that's two and not one. Second of all is loosening this wax and keratin off the canal wall. And fourthly is once I've released this, I'm having to elevate it, lift it, and bring it through that narrow aperture at the top of the ear canal that you can see the roof. So it was quite challenging, and I did highlight to the patient. I did pause momentarily and just explain to the patient this is going to be a very patient procedure because of the complexity. And at any stage, if it does get uncomfortable, do let me know. The last thing we want to do is cause any pain or trauma, but he wasn't feeling any discomfort whatsoever. Halfway through the procedure, I don't know whether you'll be able to visualize it, but I did ask the client to actually help me. So this is his left ear, and I asked him to get his right hand, wrap it around the back of his head, and with his fingertips elevate. I think this is the point now. It's a slightly different angle now, and you can see there's a bit more of an opening there. And I've entered with a standard Zollner suction probe now. So he's actually lifting the ear slightly for me to kind of just stretch open that roof of the ear canal, which did help because ideally with the standard Zollner suction probe, you can see I've got a good grip. Well, it's hard to see because of the limited view, because of the swelling, but you can just see just to the left of the swelling some dead keratin there that I was able to lift. I was having to be quite cautious because obviously I don't know what's behind that swelling. There could be an additional swelling. There could be a perforation of the eardrum, and during these COVID times, if there was a perforation and it was active and it was wet, we have to cease the procedure because it has been documented that coronavirus, COVID-19, can kind of settle in the middle ear, on the middle ear mucosa. So the middle ear, the cavity behind the eardrum, does connect to the back of the nasopharynx. So there is an entry for coronavirus to enter the middle ear, and it is strict guidelines at the moment that if someone does have a wet perforation, so an active discharging perforation, that we stop the procedure because the procedure then becomes an aerosol generating procedure, and it can be putting both myself and obviously anyone else or clients visiting later at risk. So you can see there I have got a lot of that wax out, but this swelling is quite lateral, so beyond that the ear canal itself was really impacted with wax, and so we've got another layer there. It's quite dry, and if anyone has been watching my videos in the past, you know that I've got a particular technique. I tend to wriggle the wax and dead skin in concentric circles, and what that does, it loosens and it kind of lifts the dead skin and wax off the canal wall, which then enables me to extract it from the ear. And you can just see that there. Again, it is very difficult because that ear is very kind of swollen. That aperture is very, very narrow. And again, I think the video itself sometimes doesn't actually do it justice. I think it looks a lot larger than it is, but believe you me, that is a very narrow entry to the ear canal. You can see I've got some wax and dead skin off there, and again, it's a very patient procedure, this, and it's just kind of I'm just going to be repeating myself. I'm just going to be going in and out slowly. You can see the pressure I'm putting at the roof of the canal there to bring this wax through, and you can see the top part of the ear canal, the roof of the ear canal, the superior, the cartilage aspect there. It's actually moving up and down. I'm having to be quite vigorous here. I'm having to go not only in circles but up and down to loosen this and lift this wax over the swelling, and you can got a bit more there, and you can see that slowly but surely I am making progress. Again, I was asking the client throughout whether they were experiencing any discomfort, and to my surprise actually, because you could see there I was having to be quite forceful, and the client was not experiencing any pain, and there's a big chunk of wax there and dead skin, and as I extracted that there was some more. I suspect if that swelling wasn't there, that would have all come out in one big piece, but that swelling did actually stop that from coming out in a large segment. And again, I'm just there it gets a bit tricky because now we're approaching the eardrum, and that's the very medial wax, and you can see it's quite dry, and there's a lot of keratin, dead skin around the edge of the wax, adhering it to the canal wall. So see, you're not hearing the live audio, but at the moment I know, not only visually but audibly, is when I'm approaching the wax, you hear the noise of the suction probe change slightly. And that's when you know you're kissing the surface. And again, another large piece of wax. And I was hoping that would be all of it, but there is a bit more there. In a moment, you will see the second surprise of this video. The client actually had a second swelling, and that was on the anterior canal wall and also at the base, so inferiorly. You will see it in a moment. At first, I was wondering whether it's a piece of dead keratin, and whether it's possible for me to remove. And I think you'll see after this piece of wax is being removed. But actually, no. Upon further investigation, I did again make contact with that second swelling, just to see whether it was soft or hard. Because if it was hard, that could be an osteotoma. Or exotosis, so swimmer's ear, and that's just a bony spur. And we're not particularly overly concerned with bony spurs. What we are concerned about in ears is when, just like in this case, the swelling is soft. Whenever there's a soft swelling, you just have to be cautious, because any soft swelling in the ear could be potentially cancerous as well. So at the beginning of the videos, I gave you a number of possible kind of things that swelling could be, and to add to that list, it could be cancerous as well. So this patient is going to be referred to ENT. Not even sure whether the doctor's fully examined the ear, because it was a remote consultation. We're tending to find quite a lot of that at the moment. We're getting, and it's no criticism of doctors, I know there's tough times, but we are seeing a lot of patients now who are being misdiagnosed for earwax or an ear infection, and some people are having an ear infection when they come see me, and they've been advised it may just be earwax, to use olive oil drops, and vice versa. So I do think for cases like this, it would be very useful for doctors to pre-examine the ear. I mean, it's not possible to, I know in many cases, if someone does call me and they're unsure whether they've got earwax, just by asking a few simple questions, I'll be able to ascertain whether it is most likely to be earwax or an ear infection or something else like eustachian tube dysfunction, but it's never bulletproof. So these kind of cases, especially, see that does need kind of for onwards referral, so that does need to be checked out. So I do hope now, given the situation has slightly improved, I don't want people to become complacent in the UK, that doctors are readily more happily seeing patients face to face to make these clinical judgments, and patients feel a bit more relaxed going to see the doctors. I know there's a lot of patients who have contacted me that they don't feel comfortable or safe going to a GP practice, and they'd rather come here, which is fine. But in some instances, obviously, I do need to refer back. As audiologists in the UK, we're currently not being able to prescribe medication, and it's something that I think should change. And I know one of my colleagues, who's an ENT surgeon, Mr. Darish Rajali, who I mentioned earlier, does feel that should also be the case with audiologists, and there's other professionals like opticians and physiotherapists. Sorry, I didn't quite edit that bit out, so I went out the ear, but it's just going to go back to the ear. Now, here is, in a moment, just removing some dead keratin, but you will start seeing that second swelling, and it's just beyond this first one at the base on the anterior canal wall, which is the front part of the ear canal. And I'm just making gentle contact there. There it is there, and it's got a layer of keratin over that swelling, but if you look through that keratin layer, you can see the fleshy kind of swelling, so it's not earwax, it's not dead keratin, it is actually a second swelling. So what I'm doing here, I'm actually directly on the eardrum now, and there's some wax posteriorly and inferiorly that I'm just gently wriggling to kind of loosen. It would have helped if I used some drops, but again, because the ear is already infected, I just really wanted to avoid any drops there. So I was just, as I said to the patient, being very patient myself, and just using a fine end gauge, which does get blocked quite often. So obviously I've edited all that out, but quite often I had to come out of the ear and use a cleaning rod to push through any debris that's blocking the tube and stopping the suction power. So again, just on the eardrum there, you can see that swelling at the base, and then the wax is resting on top of it, and there's a big piece there. I was actually quite surprised by the quantity of earwax and dead skin I removed, especially considering this the swelling and the narrow ear canal. So you can just imagine how compacted this earwax was. I did explain to the client that the infection is still active. Me removing this wax is not going to get rid of that infection, so he would need to, obviously we've written to the doctor, and the doctor is kind of partially aware of the circumstances anyway. But what was quite reassuring, and it was a nice feeling actually, is that this client, when they did arrive, they were really down in the dumps because they've not been able to hear for a few weeks, and the client, he felt post-procedure they were able to hear just as well as they normally would, despite all these kind of swellings and kind of the infection that we spotted in the ear. Again, so I'm just going back with a fine end, and I'm sorry if it's a bit boring, but this is the reality of being a clinical ear care specialist. And again, I'm just making contact with that soft swelling. I just want to double check it's not hard, which it wasn't, and whether that's not a ball of wax or dead skin, and it's not. And you can just see through, especially on the left-hand side, the anterior canal wall, where at the fleshy part where it connects to the canal wall. So that is a fleshy swelling. It's a soft fleshy swelling. It's not a ball of earwax, and obviously we're gonna leave that there. And again, I'm just making soft contact again. I'm just trying to gently peel off a layer of keratin just to reveal that a bit better, so I got a better view. And in a moment you will start seeing the eardrum in the distance. The reason why it's dark is obviously the channel itself is quite narrow, so I've had to reduce the exposure, how much light we shine, because when you've got a narrow ear canal and you have the light on too much, you do get a reflection. So you can, at the moment, you can see the kind of posterior part of the eardrum, and there is some wax anteriorly. So I'm just going to go back in with a fine end gouge. And the client was really good. He was helping me by lifting the ear, which did help. I would have still managed, but it's always nice for patients to help wherever they can to feel part of the procedure. And you can see just by the client lifting the ear canal, stretching the ear, elevating it, that it has opened up the ear canal a bit more. And you would never imagine I would be able to get this view when I showed that introductory video pre-procedure, but you can see there the amount of wax I've actually removed, and by the client elevating the ear, that really did open up that ear canal up for me. And you can just see the handle of malleus, which is the hammer bone just there. So the visible aspect of the eardrum, it looks intact. Obviously we don't know whether there's a perforation behind that. I mean, I've had it in the past where that swelling, the second swelling, was actually part of the eardrum. They had some glue ear fluid behind the eardrum, and it was bulging the eardrum, but that bulge was so extended, it's very unlikely by now that eardrum would have been perforated if that was fluid behind the eardrum trying to release itself through the eardrum, bulging it. So I hope you enjoyed that video. You would have seen a still shot there with the wax being removed. And thanks again for watching. If this is the first time you've watched one of my videos, please do subscribe or follow, whether you're on Facebook or YouTube or Instagram. If you are on YouTube, also when you do subscribe, do select the bell icon, and that will notify you as and when I upload new videos. So I'm hoping I'll get another video uploaded later on in the week, and in the meanwhile I hope everyone is keeping well and safe, and I'll speak to you shortly. Thank you.